Hello, everyone. This is Kwaku Ohene-Frempong. I'm speaking to you from Accra, Ghana, and I'm speaking on behalf of the SPARC0 Standards of Care Working Group, of which I'm a member and a co-chair. Today, I'm going to speak to you about some work that SPARC0 and SADC have been doing to develop standards of care for management of sickle cell disease, targeted primarily to sub-Saharan Africa. So, to those of you who may not be familiar with SPARC0 and SADC, just quickly, it was back in 2015 that the National Institutes of Health, through the National Heart, Lung, and Blood Institute in the US, announced this funding opportunity to establish a consortium called Sickle Cell Disease in Sub-Saharan Africa, collaborative consortium. And the idea was to bring together some centers of treatment and research for sickle cell disease to begin to plan future research projects. At the same time, there was a announcement to establish a Sickle Cell Disease in Sub-Saharan Africa Data Coordinating Center. So there were two funding opportunities that were announced. And after we went through all the applications from at least maybe 4 competing applications, what became known as SPARC0, which is the Sickle Pan-African Research Consortium, and its partner, the SickleInAfrica Data Coordinating Center, or what we call SADC, were successful in their applications. And so they were awarded in 2016 the 2 grants. And the funding period for that project is a 4-year project that launched April 1st, 2017, and is going to be completed March 31st, 2021. So I'm speaking on behalf of the SPARC0, or the clinical sites part of the partnership. For the SPARC0 application, the second specific aim was to develop and evaluate a resource-based multi-level, at that time called guidelines for management of sickle cell disease in sub-Saharan Africa, in order to standardize the care of people with sickle cell disease across the regions in sub-Saharan Africa. So prior to this announcement and to our application, I just want to briefly mention that we had started a project in Ghana to develop guidelines for management of sickle cell disease in Ghana. And that had also been designed as a resource-based, multi-level guidelines. And it was a project that was launched by the Sickle Cell Foundation of Ghana. Initially, it came from the Ministry of Health of Ghana. And we were timing that effort to follow the expected use of the United States management of sickle cell disease, what eventually came to be called the evidence-based management of sickle cell disease, which at that time was in development. It was an effort, again, led by the Heart, Lung, and Blood Institute of the NIH. We were expecting that to be ready by September 2012. And so we thought we would start the Ghana effort to use the US management guidelines as the standard upon which we would then adapt for Ghana. But we had to suspend our effort in 2012 because the US guidelines were not ready in 2012. But the US evidence-based management of sickle cell disease was eventually published in September 2014. And so the Ghana effort was started again in 2014. Our plan was to base the guidelines in Ghana on the recommendations and evidence that was reviewed assessed and weighted for the development of the US document. So the US document was the base upon which we're developing the Ghana guidelines. As I said, we resumed the effort in July 2014, and we were fortunate to acquire a major partner that helped us assemble the writers and go through the development process. We held our first workshop for that writing in December 2014, and we've had several meetings since then. So just briefly, we had used a classification of healthcare facilities that had been developed for the World Health Organization that classified both inpatient. Yes.
Sorry,
can you hear me? Hello.
Kof, please could you make your slides in mode and also move them? They're not moving at the moment.
They're not moving. Okay, I'm yes. On. So I was on show mode, but I should go into. I'm moving here, but you can't see them. They are in view mode. You want me to take it out of view mode?
Yes, in presentation mode, and maybe you know, because they're not moving from slide to slide. Yes.
Really? Okay. I'm using the arrows on the screen itself. Maybe I can use the arrows on my computer and see. You see any movements?
Kof, could you leave
yes.
things as they are? Hold down your Apple key on your keyboard, and then use the tab key. So when you share your screen, so unshare your screen, and then when you do share your screen, just select the presentation. So what I suggest you do is leave things as they are. Hold on the Apple key, press tab until you get the browser that you're using. And from there, you select the sharing of the of your presentation. So the Apple and Tab key allows you to go move between applications.
I know. I see otherwise the PowerPoint. I see. So should I stop showing the screen at this time?
Yeah, in the interest of time, maybe you can. Okay. I think, Prof, if maybe in the interest of time, maybe just take the presentation out of presentation mode and maybe just click on page down for each. There we go.
Yeah, I think it's now showing. Thank you, Kof. Thank you, Mario.
There we go.
It's showing now?
Yes, it is.
Okay, so I'm out of presentation mode, and you can see the screen. So I go slide by slide.
Yes, Kof, we can see it now.
Hello. Okay.
You can see it now, Kof.
Do you need me to go back, or it's okay you are? So I'm showing a slide that has the classification of the health facilities, and this slide shows 3 classes of outpatient facilities, and it starts with a standard level that is labeled as level 5, and this, by that World Health Organization classification, is the last referral hospital, and it would be an example would be a university teaching hospital, or the highest level of medical care available in that country or in that region. The next level down is a limited level now, not the same level as the standard, and this is level 4, also referred to as a secondary referral hospital. This, in many countries in sub-Saharan Africa, may be a regional hospital. It could be private, government, or mission hospital. or in some countries, it may be a community hospital. This is a facility that may have multi-specialists, has both inpatient and outpatient care, and it may have some special expertise in some particular diagnostic or treatment area, for instance, a TB center or a leprosy center, in addition to being a general hospital. The next level down is level 3, also referred to as the first referral hospital. So it would be the first level of inpatient care in a community that may be relatively small, such as a district hospital. It could also be private, government, or a mission hospital. They also would have intramural medical care at a level of complexity that is below the level 5 and level 4 facilities. So the next group is a group of outpatient facilities. And the highest level of outpatient facility will be classified as level 2 health center. It may have ambulatory and curative services. It may be involved in health promotion, prevention, education of patients. It will support a lower level, level 1 hospital where there may be no doctors. This level 2 health center may be able to deliver babies, observe patients who have minor surgery, and it may serve a community of about 100,000 people. Below that, it will be a level 1 health center. And in Ghana, the level 1 health centers are classified, they're called community-based health planning and services compound, or CHIPS compound. There is no doctor. It's run by nurses, one of whom is trained to be a prescriber, and usually will serve communities of less than 10,000 people. We decided to also add a home level we call level 0, and that would be a home or a child care facility or a school where people with sickle cell disease may be as children or adult patients. At home, the instructions from these guidelines would be instructing parents and other caregivers, and at school, it will be instructions for the teachers and others. So to give you an example of how we designed the recommendations that would be made for these types of different levels of health facility. So the last referral hospital is like a teaching hospital, and instructions on screening children for stroke risk using transcranial Doppler ultrasonography, or TCD. So for the last referral hospital, it is assumed that they have TCD capability. So the recommendation says obtain TCD at least once annually in those with sickle cell disease SS or sickle cell disease S-beta-0. If TCD is not available at your facility, arrange for the child to visit a center where it can be performed, or arrange for portable TCD to be performed for children at your facility on a periodic basis. Now, at the outpatient level health center where there is no doctor, the screening for stroke recommendations would be different. It would simply say refer children with sickle cell disease SS or S-beta-0 to the regional center for sickle cell disease annually for comprehensive evaluation, including TCD, at least once a year. It is assumed that that facility will not have TCD capability. Now, for the family at home, they also need to know about what can be done to screen patients for stroke risk. And so at home, the parent will be given these recommendations. If your child has sickle cell disease SS or S-beta-0 type, ask your doctor or nurse about a test called TCD. This test, which detects those children who may be in danger of having a stroke, needs to be done at least once a year. So this is an example of taking the same instructions and passing it through different levels. So after the award was made in 2016, and we knew we were starting in 2017, we began to organize ourselves for this new project. So for this particular specific aim, the main objectives and timelines we established were that we would review existing standard of care guidelines, both in Africa and outside Africa, and we will develop and compile locally feasible and resource-based consistent standards of care for managing people with sickle cell disease. We would eventually introduce these standards of care at the SPARC0 sites, the sites that were participating in this project, and eventually to make them available to other sites in other regions and other countries. And that in year 4, we can evaluate those standards and see how they are operating. So I wanted to just spend a little bit of time talking about guidelines and standards of care, because sometimes we use these terms interchangeably. And there have been attempts to just give a little more education about why we use these two types of standards. When we applied for the grant, we called it guidelines, but by the time we started writing, we had changed it to be standards of care. So clinical guidelines are systematically developed statements designed to help doctors and patients decide on appropriate health care for specific clinical conditions and circumstances. Guidelines should provide extensive, critical, and well-balanced information on the benefits and limitations of various diagnostic therapeutic interventions so that the physician can carefully judge individual cases. As an example, in the UK, guidelines separate from standards of care, the NHS, the National Health Service, has stated that clinical guidelines can only assist the practitioner. They cannot be used to mandate, authorize, or outlaw treatment options. So guidelines can be looked at as advice, the best advice available that can be given to health professionals, but they are not mandated to follow guidelines. Now, when we mention standards of care, there is one definition that says the medical standard of care is the standard required of doctors and other medical personnel. So standard of care actually requires you to do something, and they are often based on the resources available to you and the community where you are. So that's the difference, slight difference. One is mandatory almost, and one is really just advice. So the first thing that we did coming together as grantees of SPARC0 and SADC was to form the working groups or the committees that will pursue these projects. So for the standard of care group, a working group was formed, and I've listed here the members representing the 3 sites. Tanzania, which served as a site, a clinical site, and also hub for the entire SPARC0. Then a site in Kumasi, Ghana, a site in Abuja, Nigeria, where the representatives came from. Along our work, we realized that us on the committee had much expertise in psychosocial issue related to sickle cell disease, and so we did ask a friend and a colleague, Prof Ohene, who is based in London, to become a guest member of the working group to help us develop the recommendations for psychosocial issues. We set ourselves some key milestones that we wanted to guide our work in the first 4 years of the grant. First was that we would review all the existing guidelines. We started thinking mostly about the English language guidelines that could inform us on our task. And then we would set to work to develop these locally feasible and consistent standards of care to be developed and compiled. Then by year 3, we would introduce these standards that we've developed for the SPARC0 sites to evaluate them in sort of field testing and eventually make them available to other sites in the regions where we are located for them to be adapted for implementation and delivery in healthcare. This slide has a lot of information that you cannot read, but we developed a spreadsheet system for tracking our activity. And this is just an example of the details of the work that we set ourselves to accomplish in order to reach those broad goals that I had shown in the previous slide. So I'll move on. So the first task was to review the existing guidelines that had been written for sickle cell disease in different countries. And we started working mostly, as I said, with the English language guidelines. So we divided the guidelines into 2. General guidelines are addressing all the major topic areas in sickle cell disease. And then the specific guidelines were dealing with one aspect of sickle cell disease. So that was the broad division initially. And then under the general guidelines, we divided them into 2. Guidelines that were written in Africa for use by African healthcare workers, and then those that were written outside, not necessarily directed to Africa. This, we thought, would give us some way of assessing whether the guidelines that are specific to Africa will provide some information that may be missing from the others. And so the guidelines for Africa, we identified 3 of them. One was a guide developed for Tanzania in 2017, and also one for Nigeria developed in 2018, and those are the numbers in the file names. And then one that was written in South Africa also. So these were more country-specific guidelines, but they did contain very useful information. The Ghana guidelines, which formed a basis for the structure, was still in development, so it wasn't completed, although it was included in the review. Then, in addition to the 3 that were written specifically for Africa, we identified 8 and eventually actually 9 guidelines that dealt with sickle cell disease in general. Some were written for Europe, some specifically for UK, one from Jamaica, and the Jamaica one was actually not completed yet, and it was still under review. And so they gave us permission to look at a watermarked version, and then they also went on and completed theirs. The 2 of the European guidelines, one in UK and one for broader Europe, addressed children. And the UK guidelines also addressed parents, and they've also always had an adult version. So the UK has always divided the adults and children from their guidelines, but the US guidelines were addressing both children and adults. Before we completed our work in the review, the UK had renewed the adult guidelines, which came out in 2018. So we added it to the list. Now, the specific issues guidelines addressed transfusion from UK, also pain management, also from UK. From the US, written for family physicians, addressed pain management. And there was another US guidelines that was meant for emergency room application that was developed by the Centers for Disease Control and Prevention. So the main work for the committee then was to go through these guidelines, list all the topics that were addressed in the guidelines. Then we came together as a committee to try to unify the topics to make sure that all the essential topics that would apply to Sub-Saharan Africa were addressed. And then after we listed all the topics, added a few and took out a few, we divided the work among the committee members. So the next series of slides will show the classes of the topics and also the specific subtopics that were used. In the interest of time, I'll just go through just the classes. So for instance, on subject area 1, we address diagnosis of sickle disease and related conditions. And then we go through sort of the laboratory procedures and what capabilities one must have in order to properly diagnose sickle cell disease. The area number 2 was health maintenance and preventive therapy. As you can imagine, this was extensive, addressing many of the things that we do to patients and hopefully prevent or reduce the morbidity of disease. And so for children, things like immunizations, the penicillin prophylaxis, immunization for pneumococcus, which may be specific for sickle cell patients, but not for the others, going all the way through to even the adults, some issues to deal with monitoring organ damage in the adults. Here also we added something to do with education and psychosocial counseling that also needs to be managed as part of a health maintenance preventive approach. The third group of topics dealt with screening for specific complications of sickle cell disease. I mentioned an example as screening for stroke using transcranial Doppler ultrasonography, MRI where it's available, screening for renal disease, screening for retinopathy, pulmonary disease, cardiovascular disease, and so on. So these were for specific complications of sickle cell disease and what could be done to screen for them. Group number 4 was the management of acute complications. As you can imagine, it's for the acute complications that most of our patients would go to emergency rooms and be hospitalized in places where they may not necessarily be cared for by people who have expertise in sickle cell disease. So what you write here, the recommendations here are often meant for colleagues who are specialists in other areas. So it's very important that we make sure that we assume nothing and that we bring our colleagues who are subspecialists in other areas to be able to manage sickle cell patients appropriately. And the topics here are listed. The next group dealt with the chronic complications of sickle cell disease. As we know, the disease has both major acute complications and chronic diseases, and they're all listed here. Then the last category, category number 6, were the special management protocols. And examples would be analgesic medications and how they can be used properly and their risks and benefits assessed. Emergency management plan, which plan for stem cell transplantation, intravenous hydration guide, in managing patients, hydroxyurea therapy, preoperative care and surgery, transfusion as special care for sickle cell disease patients. And also, as a last point, just a general idea of how to organize a sickle cell clinic for both outpatient acute care and also inpatient care. So this is very extensive, and we thought that this will cover most of the areas where clinicians need some recommendations. So we have gone through many of these. We're just ended year 3, and we are moving to year 4. And these check marks here sort of list what we have been able to accomplish. We haven't finished everything that we plan to do, but where we are currently is that the most sophisticated of the guidelines, the level 5 or hospital level standard is completed and has been internally reviewed by the SPARC0 clinicians, and we are making them available for external review. And then we are beginning to design, draft the lower level standards based on the classifications that I presented earlier. when we are finished with all of that, we also need to provide a little more information, some notes and references to guide those who are not sickle cell experts so they can understand the sources of information that we use to draft these standards of care. We plan to field test these guidelines. I'm not sure whether we'll be able to do it all in year 4. I can say that the guidelines that we designed for Ghana have also become informed by what we're doing for SPARC0, because you can't really develop 2 levels of different types of education. And we are lucky to have some help to do some field testing of the Ghana guidelines this year and next year. And what we are hoping is that we can incorporate the field testing in Ghana into the SPARC0 field testing at selected sites around the continent, even beyond the 3 sites. Hopefully by the time we're doing this, additional sites would also have been added. Initially, our completion goal was to try to finish this by the end of this cycle, the year 4. It's optimistic, but we'll see whether we'll be able to accomplish it. So I think this, in summary, is what we've been doing in developing these standards of care for SPARC0. And maybe when we finish everything, we'll come back to see what we did is guidelines or standards of care. And if necessary, we may need to rename it. Thank you very much for your attention.